Yeah, dear Pure Urology viewers, good evening, one and all. Today, I'm going to introduce my friend who is dedicated and has done a lot of research after the fellowship, Esteban Emiliani, and he will talk about the RIRS latest advances. He is currently in attending urologist of the endourology and urolithiasis unit at uh, Foundation and the University of Barcelona, specialization studies in endourology and medical surgical treatment of stone in two of the most prestigious institutions worldwide. And he is attached to the Tenon Hospital under Professor Oliver Traxler. And he also went to a good institute in India, MPUH, where he has and done under Professor Mahesh Desai. He has worked and he published more than 100 articles in indexed urological journals, 12 publications in non-indexed journals, and has written 4 international book chapters. He is member of the editorial board of the World Urology, Spanish Urology Acts, the Turkish Journal of Urology, and BMC Urology. He is member and secretary of the Petra Group's research group led by Professor Oliver Traxler. As you all know, Professor Oliver Traxler has done a lot of research. Those who have done fellowship under them are doing excellent. One of the favorites of Oliver Traxler is Mr. Esteban Emiliani, and he is currently practicing endourology with a lot of academic research. So let us listen from him. What's the future? What is the present? What's going on with RIRS? As you all know, the smaller size of the scope, the digital scope, disposable scope, smaller laser fibers, all the things are changing a lot in the last 1 decade. So let's listen from him. What's the present and going to be the future in RIRS in form of latest latest things about RIRS. Now over to you. Thank you very much for Dr. Esteban for joining with us, and a lot of people around the world will watch your program as you are a well-known person. Thank you once again accepting the invitation. Over to you.
Thank you so much, Chandra. Thank you so much for the invitation. For me, it's an honor to be here again with you. My second invitation, actually. So yeah, let's talk about what is new in endourology, specifically on flexible urethroplasty, and let's go to it right away. Those are my disclosures. And actually, the real disclosure that I want to mention is that as these are new things that we are seeing in our field, we have to take them with a grain of sand because there's not a lot of studies and there's lots of lacking of standardized techniques with these new techniques. So maybe these are promising things, but we need more studies to validate all of them. So this is a thing to mention at the beginning. So let's begin to talk about urethroscopes. We know that there are 3 kinds of urethroscopes right now, widely available: the fiber optic ones, digital ones, reusable, and now we have the digital single-use ones that we have been using since 2017. And I remember the time where there were just only one, the LithoVue, where then Pusen came along, and now we have more than 20 single-use urethroscopes on the market. So this is just a big picture of what I've seen. I haven't seen all of them, but now this is something that is widely available. Most of you use single-use urethroscopes, and I think the trend towards the use of single-use urethroscopes, it's going to continue. And it is the present, and it's going to be the future. So good thing, most of them have optical digital imaging. You can see, or these are CCD or CMOS optical imaging. This is great because we can do our procedures quicker and in a very good fashion. We have seen this and we have compared this between all, some of the first scopes available, and they were completely similar between them regarding field of view, resolution, depth of view. So they have pretty good digital imaging, as you saw. There are some of them that are hybrid. These are single use, but you can use them a couple of times. For example, those semiflex, you can use it 10 times. There are some that you can reuse some parts. And I think this is very important because we need to ask companies about sustainability regarding single-use scopes. And this is a great first step and a way to go towards the better and proper use of single-use scopes, the hybrid, for example, version or the recyclable version. These single-use scopes have been compared to reusable scopes, and they are completely comparable in clinical settings. They're good for ergonomics because they are less heavy, let's say. You use less your muscles to use it, and it avoids some problems as sterilization issues that we have had in the hospital, as you can see here. But also we have trouble with single-use scopes because we need to ask also the company to make good quality single-use scopes. This is a brand new scope that I used, and look what happened. So this is also a problem with this kind of instruments. There is no perfect instruments. Now, there is a problem now, we are learning more and more about intrarenal pressure. We know intrarenal pressure it's a major or an important thing to consider during flexible ureteroscopy. We can manage inflow and intrarenal pressure by using some irrigation method, and by the size of our instruments, we can modify this. But also, if you use, for example, an access sheet or the scope itself, we need to have a good outflow to have low intrarenal pressures. A good ratio is 1.5 centimeters, 1.5 French between the scope and the access sheet, to have a good outflow. And some of the new things that are really, really interesting are the smallest scopes available right now, which is, for example, a 7.5 French scope. This was something very good because it reduces intrarenal, it can reduce intrarenal pressure because of that ratio that I mentioned, for example. And in a clinical setting, they are completely comparable. When you use it, the maneuverability is very good. It's, as you are seeing here, is a just plug and play system. You just do your white balance and you're ready to use. You can see that they have a digital vision and the maneuverability is very good. So this is a very, very interesting concept because smaller is better, especially when we have small ureters and you'd want to decrease the lesions to those ureters to use smaller access sheets or to increase the access to the kidney. You know that there's a 3 to 10%, let's say, failure of accessing the kidneys. And this is because we have big instruments. But if you have 7.5 French or less instruments, this will be diminished at maximum. They are completely comparable between them, the LithoVue and both Poussin 7.5 and 9.5 French in clinical settings. So we have seen that these are good instruments to use. As I mentioned before, between a 9.2 and a 7.5 French, you reduce the outer diameter by 19%, and you have 147% more outflow. So this is very important to have this ratio and decrease intrarenal pressures and be on the safe side. Now we have even smaller scopes. This is a test from Professor Traxler. This is a huge med scope, which is 6.3 French. This is almost the size of a stent. Maneuverability is good. You can see it's a great image, digital imaging. So think that with this scope, you won't have any problems accessing the kidney. It's the same size of a stent. So if you want to place a stent and repeat the surgery 1 week after because you couldn't do it, with these scopes, you will have let's say, that sorted out. So that's very good. A good thing about the future is that with these single-use scopes, you can invent and have some new gadgets that can improve. Now, one of the only gadgets that we have is the Empower, is a self-basketing machine that you use with a trigger, with the LithoView, and you can self-basket. And this is only just one example of what can be done in the future to improve the efficiency of our surgeries. And that's it about urethroscopes. Let's talk about lasers now. I want to talk about, firstly, about holmium YAG. Holmium YAG is the gold standard of lasers because we have using it for now. It's the gold standard. We have been using it for more than 20 years. And it's great because it breaks all of the stones very efficiently. Now, we had lower power settings with a single cavity producing that power of 30 watts. But now we have high power lasers. When we have multi-cavity lasers, these multi-cavity lasers produce the, let's say, the energy between them, let's say, and we can reach up to 6 joules, 120 watt, 120, 150, 120 hertz, 120, 120, and 50 watts. So we have high power lasers now. And with these high power lasers, we have new pulse modulations, which is the new thing of holmium YAG. We left behind the single pulse, single bubble emission. You have single pulse emissions of that laser to have multi-pulse and multi-bubble emissions. That means that the same amount of energy is going to be emitted in different periods of time. So you can emit it in 2 times and you have these 2 bubbles as the MOSES, or you can emit it in multiple timings, and you will have different versions of this. This was done to reduce, let's say, the amount of energy release and reduce retropulsion. You can see that pulse modulations reduce retropulsions, and you reduce the peak power. Here, pulse modulations are seen in the red and the black graphs, and you can see that the peak power is lower compared to the green one, which is basically short pulse, where all the laser emission is emitted instantly. So you use that for fragmenting, and the lower peak powers, let's say long pulse, and the new pulse modulations are used for dusting because the energy is going to be released, let's say, in a slower way, in a longer pulse, and the effect of the stone is going to be more of scratching rather than fragmenting. So use this for dusting. The first one was the MOSES technology that you know from Luminis, now Boston, and you emit the energy in 2 timings here to have 2 bubbles. We have other systems. For example, the Quanta system, we have the virtual basket, which is exactly the same, emitting the energy in 2 timings. So you have the double bubble, you have the vapor tunnel, which is seen in the upper video, or the Q wave. We usually use a virtual basket or vapor tunnel for our stone lithotripsy, and you can see here that those long pulse modulations of low peak power are very good to dust. We can dust hard stones, which are not hard for the laser, as calcium oxalate monohydrated stones, or we can dust soft stones for lasers as the uric acid stones. These are some of the settings that I use, and you can see that it works pretty well. We have looked at this in our, let's say, we did some kind of experiments, in vitro experiments, and we saw that most of them, of the long pulse modulations, are very similar to long pulse. So what we want to do is to, let's say, get this lower peak power to dust better the stone. The latest technology in this situation, in this regard, is the magneto from Quanta, which you can see here, which is a super long pulse that it's delivered by the machine, and this reduces the retropulsion a lot, and this increase the efficiency in dusting. So we need to check this out in the literature. In an academic setting, it looks great when you see how it functions, but we have to figure out if this is really a step over being more efficient. There's some other industries as the Olympus with the stabilization mode, for example, but there's no data on the literature, or Dornier has the advanced mode, but there's only one in vitro study. So we did a systematic review about regarding all these pulse modulations, and what we saw actually it was that there's a lack of clinical studies to really let's say recommend one over the other. All are good, but they're very similar on operative time, stone-free rate, laser time, or complications. So let's say my recommendation will be that if you have it, you can use it, either one of them, if you want to dust the stone and reduce retropulsion, but you can also use a long pulse, which are also, let's say, good for these kinds of situations. Something that it's relatively new, now it's not new, which is the thulium laser fiber. It's a different laser. You know that it's a 30-meter, it's a laser emitted through a very extensive fiber, which is 30 meters long, that has some thulium ions, and is let's say the main source of energy are diodes. So it's a very different concept from holmium laser. This is a thulium field with a thulium field laser fiber. This is how it looks, the pulse wave laser. And as you saw in my previous slide, this was represented by the blue line, which is 4 times lower peak power compared to holmium. You can see that it's longer and that it's lower peak power. You can use for soft tissue, as it has very low peak powers, is very good for coagulating, so it doesn't bleed when you treat soft tissue, and is a pulse laser still, so you can use it for stones. You can increase the setting range is very high. You can increase up to 6 joule, and you can increase up to 400 hertz, which is not recommended. Because you have to be on the safe side, and I'm going to talk about that later. Ideally, for stones, you have to use short pulse regarding pulse modulation. So remember, short pulse always for thulium fiber laser. As you can see here, you can compare the blue graph, which is TFL, which is 4 times lower the peak power compared to holmium, and it's a square. It's not just a peak. So you have a longer, more stable pulse duration, so more energy delivered constantly to the stone. So it may be more effective when dusting, because you have less retropulsion, because you have lower peak power, a very continuous energy delivered with a longer pulse duration. You scratch, let's say, better the stone rather than fragmenting the stone, because the peak powers are low, as I mentioned. So better dusting, and you have high water absorption. So it's very safe. This can be delivered through very small fibers, smaller as 150 microns. These small fibers are good because it lowers the temperature, and you have a better irrigation. Because they are small, you have better irrigation, and they transmit better the energy compared to larger fibers, as you can see in the graph. So the big problem with this is that you can have high power and high frequency. And this is very, and this has been of concern, because with high power and high frequency, you may cause urethral damages. and very easily, because you increase the temperature and you don't have laser control. You cannot control 400 emissions per second in the ureter. So you have to be in a safe profile. You have to use low watts and low hertz, especially low watts and low hertz for the kidney, and low watts and low hertz for the ureter. What I use is less than 20 watts for the kidney, and I keep the same number for the hertz. So less than 20 watts and less than 20 hertz for the kidney, and I do the same for the ureter. Less than 12 watts for the ureter, and less than 12 hertz for the ureter. So I can be on the safe side. Don't use more than this. And this is specifically important because you can increase that frequency up to 400. And remember, more than 500, more than 50 hertz is just an increased risk for the ureter. So use less than 20 for the kidney and less than 12 for the ureter. So what does the in vitro studies are saying? That TFL has better ablation compared to holmium in case of dusting. TFL makes smaller fragments and is faster. I really feel in my personal practice that I'm faster, almost 2 times faster than with holmium. And this has been, let's say, shown in clinical studies. This randomized controlled trial by Ulvik comparing TFL to holmium 30 watts. TFL was faster, had better stone-free rate, and has less complication rate. But in this RCT comparing TFL to holmium YAG high-power laser and pulse modulation, they had similar operative times, similar stone-free rates, and similar low complication rates. So let's say it's a debate that it's ongoing. If you have big registries as this, as the Flexor registry, there's a tendency to go towards TFL for better lacing time and better efficiency. And in systematic reviews, as this one that we did very recently, there's also a tendency towards TFL to have better stone-free rate and better operative times. And you can see it when you do flexi with TFL. You can see the micro dusting that it generates, that it's amazing. And this opens the door for the future, which is aspiration in flexible ureteroscopy. Now we have the thulium YAG, that before it was a continuous mode. It didn't have these pulses, but it was a continuous emission of the laser. So you can treat only soft tissues, and you can treat really good, for example, upper tract tumors just with watts. But now we have a pulse thulium YAG. So you can treat soft tissue, and we can treat stones. There's 2 in the market, the Revolix THL and the Dornier, and the Thulio from Dornier. They have the captive mode, so it's a long pulse, as I mentioned, to reduce retropulsion, as you can see here. And if you see the pulse is almost, it's very similar to the holmium pulse modulation. It's like a double pulse emission. There's also a very interesting thing described, which is a suction phenomena that you see those bubbles that went behind the laser to the laser fiber. So this also may, let's say, help theoretically with retropulsion. It has been shown that you can treat all kinds of kidney stones with thulium YAG, which is good, and generate dust particles. As for what Professor Traxler has described, less than 250 micrometers, which is a definition made of what you can aspirate from your working channel and what you can eliminate with the normal flow of urine. So this is what is dust at the end. So you can use long pulse, use longer pulse, and you can see how you can dust very well soft stones with very similar settings to holmium. You can see it's 12 watts, and you can dust very well also hard stones if you increase a little bit the energy. So very similar settings to holmium YAG. So the preclinical studies have shown that thulium YAG maybe a good compromise, an in-between laser, because it has shown to have a good fragmentation performance equally to holmium, and it has shown to have a good dusting performance equally to thulium fiber. So it's a good laser to have the best of holmium and the best of thulium fiber laser. In my regard, it lacks a little bit of energy to be as good as holmium. I use holmium for all my PCNLs, for example. It lacks a little bit of energy, but it's an ongoing technology, and it's going to be a very good in between. What is, let's say, most the Magneto is doing also. It can be compared a little bit with TFL. We're going to study this, and still a holmium laser. So we are looking for this in between lasers to do the best of each scenario. And you can see the dust quality at the end is very similar to TFL. So these are very good. And the few clinical studies just have said that it's a safe and effective technology. And let's finish with pressure and suction, which is one of the most important topics nowadays in flexible ureteroscopy. We know that intrarenal pressure is very important because it's the cause of most of the complications in flexible ureteroscopy: bleeding, fornix ruptures, urinoma, sepsis. You can have intrarenal reflux when you increase up to 27 to 40 centimeters of water, as you can see on the left. When you see this, is not good because you have intrarenal reflux. And when you see the renal vein with contrast, it's even worse. You have increased the frequency up to 40 to 78 centimeters of water. The normal intrarenal pressure is almost zero. Is a system that collapses because the pressure is very low. So this is very important, and this is a risk because you are taking all this bacteria from the urine and taking and putting it in the vascular system. So this leads to sepsis. Very important. So sepsis in general is a small percentage of the complications of flexible ureteroscopy, only 5%. There's some things related to the risk of sepsis that we cannot modify. For example, the gender, a prior sepsis, a stent, maybe modifiable, the stent, the stone size, but there are modifiable risks factors as high intrarenal pressure and longer operative time. What we do generally here is that we put a bag 40 centimeters above the patient to have 40 centimeters of water of gravity to be in this theoretical threshold before intrarenal reflux. And we avoid doing this kind of pressure systems to control what we're doing. And now we have intraoperative pressure measurements with the lithouroliter that you can see here. And this has been used in America and Canada. And the preliminary clinical studies have shown us that most of the flexible ureteroscopies are within good range of less than 60 millimeters of mercury. Some of them are really, really high and increased. You know that even in the same patient, you can have normal intrarenal pressures or low intrarenal pressures in one kidney and very high in the other kidney, because it depends on the anatomy, and the intrarenal pressures varies according to the anatomy of the patient. So one patient can even be different between both of their kidneys. Okay, it's good to have a ureteral access sheet. It reduces intrarenal pressures, and of course, if you use a larger access sheet, you will reduce intrarenal pressure, but you can increase the risk of ureteral damage. And we also saw in these papers that the Asian population has increased pressures, let's say translated to smaller ureters. There's other intrarenal pressure system with in ureteroscopy as the zebra scope. This was a video from my colleague Steffi Juen from Hong Kong. I think this can be only used in in China for now, but we are getting to this, let's say, control systems within flexible ureteroscopy. And this is 8.6. LithoVue Elite is still 9.5. So we have to measure that. We have to have also this in consideration. We have also seen other papers with, for example, this off-label use of a guide wire and that has measured the pressure. And we have seen, for example, that only gravity irrigation maintains the pressure to 60 centimeters of water, that if you use a manual pump, you can increase the pressure. If you use it gradually and you force, you can increase the pressure up to 3 or 4 meters of water. Imagine if you have a bag 4 meters or on the ceiling, you will never do this. But if you use a continuous manual pump continuously and slowly, you can keep this 63 or this gravity irrigation threshold very good. So this was very important because it showed what we already saw in some papers by Paleoster, that if you use a manual pump in a proper way, it's going to be safe. So to reduce intrarenal pressures and to help the aspiration, we have now the flexible and navigable access sheets. This is one that we have used. There's the Cleopatra, there's some others. You can see there is a common access sheet, as you can see here, but it has this special, let's say, it has this special slit on the side. So it's usually sealed, or you have to put a cap over it. And there's a special slit here that you can open or close in this case, or you just can put your finger on it to increase the aspiration. And still is a usual, besides this, is a usual access sheet. The tip of the access sheet is going to be flexible. So you can put your ureteroscope and you can bend the tip towards the lower pole, which is the main problem with the residual fragments. And you can see here that you can put a 7.5 French scope through the access sheet and you can bend it completely. So this is why it's flexible and navigable, a flexible and navigable access sheet. So what is the literature saying about this? That they are feasible to use, that they are safe to use it with the same principles of access sheet. For me, is the smaller the better. You want to protect the ureter. This is really important. There's a tendency to have a better stone-free rate, so you can aspirate all the stones, which is actually what we are looking for in flexible ureteroscopy to compete with at least mini PCNL. And there's also a trend towards lower intrarenal pressures. So this is very good. And you can see how it works. You can dust the stone. You have to pass the access sheet over the UPJ, yes, and these fragments can be aspirated with through the lumen of the access sheet. You have to, as with PCNL, you have to go back and let the stones go through those slits. And this is a great slide from my friend Said from Saudi Arabia, that it has aspirated all these stones in this, that I will personally have done a mini PCNL. So this is very good. So remember, although it reduces intrarenal pressures or going towards intrarenal pressures, I like to use the smallest because there's also the problem of lesions of the ureter. And another thing is that you have to put the access sheet over the UPJ. And sometimes this is very difficult. You can see this. This is very difficult. In this case, we couldn't just put it. So maybe this opens up again the door to pre-stent these patients where you want to aspirate and you want to use properly without doing any harm this suction access sheet. Because it's very interesting. Preliminary studies, and if you use it and you use it properly, are very good, very efficient. But there are some cases where this happens, and maybe pre-stenting may be interesting to avoid lesions to the UPJ. Also, as you can see here, the shape of the access sheet is not round. So we need to ask the companies also to produce good products to avoid any troubles. And also there's, let's say, problems with this, because as you aspirate, you can have some bleeding, you can have ex vacua hematurias, maybe you can have some clotting, you can have collapsing of the system. So there's a minimal learning curve, and it's not perfect. I cannot say that this is perfect, but it's a good first step towards aspiration and towards the best use of mini PCNA. Another thing about suction and aspiration is new flexible urethroscope with aspiration. This is a 7.5 French aspiration urethroscope. You can see that it's a normal urethroskope with the irrigation, for the irrigation, and you have this, let's say, this lid where you can press to open irrigation, and you can connect the irrigation. Remember that these new technologies have one working channel, either for irrigation or either for suction. Sorry, this button and this lid is for aspiration, for suction. So you have one working channel for irrigation and for suction. The image is as good as any other, excellent imaging. And you can see that when you're dusting, this aspiration with this really small caliber, let's say, scope, clears a little bit the vision, gives you a little bit of better vision, because it's going to aspirate some of the debris that you are using. And another thing that I like is that you can see that the system is a little bit collapsed when you use the scope. Is not bad, because you can see and you can still work, but it's a little bit collapsed. So another, let's say, good thing towards lowering intrarenal pressures. We have other system as the CVAC that it was developed in America. The problem with this is that it's 11.9 French. So we're going again towards big urethroscopes. And remember, this is very big, almost 12 French. You have to be careful with the ureter. And it has been shown that it's good. You can see now in some congresses how it aspirates the stones while you're working. It has a very different irrigation jet type towards the, let's say, is not a frontal, but a lateral jet type irrigation, and it aspirates good. This is, of course, the best video from the company, but it's, let's say, also a good initial step. Remember that this is 11.9 French, and still it's, for my opinion, is still very big, and you'll need a pre-stenting or some other, maybe you'll need some other, let's say, you have to see what you can do to put it safely in the kidney. There are other technologies being that are around, as the hydrogel, where you can put these hydrogels and all the residual fragments will stick, and you can remove them all in one piece, as you can see here. This is very, very interesting. People that have used it, I haven't used personally, let's say it may break sometime. It just don't eliminate all the stones at once, but sometimes it breaks. But it's also new technologies that are coming to eliminate all the residuals. So these hydrogels are very interesting. We have magnetic hydrogels, where you can put some magnetic components in the hydrogels, and then take them not with a basket, but with a specific magnet. So this is very interesting. Although you have this magnetic hydrogel, I don't know, we have to figure out if this is safe, but these are new technologies that are coming to remove those residual fragments. And finally, I want to talk about robotics. We knew that about the Avicenna robot. These are things that are also, let's say, being developed for flexible ureteroscopy. We have published our initial experience, just a robot to manipulate your urethroscope with, let's say, with a PlayStation with a PlayStation joystick, and you manipulate the ureteroscope as usual. It's good for your, let's say, it's good for your ergonomics. It increases a range of motion. It's the stability. It's better for sure. But this is something also, as I see it, as a first step towards robotic ureteroscopy, because we need those robots that can do what we cannot do with our hands. So new instruments from the beginning. And there's some new things also on AI, deep learning, stone recognition to recognize the stones within the flexible ureteroscopy, or recognize, for example, the size of the stones. This is something with AI that it's coming, but there's few things on the literature, so I'm not going to talk about this. So thank you so much. I think this is all very briefly what is new on flexible ureteroscopy. I hope you have enjoyed it.
Yeah.
And I'm very open for questions.
Thank you very much. So let's, it's a very good presentation, a crisp presentation. Let me ask a few questions. Can we close the screen so that we can?
Yes, I'm so sorry. Yes, absolutely.
Yeah. So my first question is, how often you don't like to use access sheet? Most of the world urologists are using access sheet for RIRS. Very few don't use access sheet and do with the ureteroscope directly. When will you use without access sheet? My first question.
So this is a great question. Now we are using a 7.5 French scope. So if I have the opportunity to use such a small scope in a stone that is not infected, is not a struvite stone, known struvite stone at least, sorry, not infected. That is a stone that it's less than 1 centimeter, right? And I know that I'm going to, let's say, 5-6 millimeters, that I know that I'm going to be very quick. And then I will decide probably not to use an urethral access sheet. If the stone is infected,
do you think with your experience, it is slightly difficult than with using access sheet? Because I use in infants, but I use access sheet in adults. I use without access sheet in infants. Usually in adults, especially with a little high bladder neck and prostate, the movements transmitted at the tip without access sheet are slightly difficult. Do you agree that scope wear and tear also can get affected, especially if it is not disposable?
Yes, absolutely, absolutely. And those cases, as you mentioned, are really good indications. Big prostates, sometimes you can see this really large kink from the ureteroscope. Is very difficult to manipulate, or even to get the access, because you cannot see very well the orifices. These are good indications for access sheets, for sure.
My second question, why all these scopes have 3.6 French as the lumen size? Nobody has changed the lumen size of irrigation channel. In large scope also it is same. In small scope also it is same. If you have large scope with irrigation channel of 5 French, then you can depend on direct intrascope suction better than fans. We are using fans regularly in India because of various reasons. It's available easily, it is cheap. We use disposable scopes again, not as a single use. So we are using large volume stones of fans more often. But Western world is still supporting direct intrascope suction. Why the lumen size, they are not changing?
This is a very interesting conversation that we're having, Chandra, because as the technology has moved, we have seen lots of movements of what you mentioned, the standard. I think this was arbitrary. Why does scopes have 3 o'clock or 9 o'clock working channels. I think companies just did what was there already, and they just replicated that. I know that there's some companies right now doing 5 French or 5.2 French flexible urethroscopes, and exactly what you mentioned. This is going to open the door for insuction or suction suction urethropy, because really small scopes can, let's say, aspirate some debris. It can be good, but it's not optimal, let's say. And this was what the people that designed the CVAC wanted to counteract, doing this 12 French scope to do exactly what you are mentioning. I think this is also a little bit big, but what you mentioned is very true. We need big working channels to have this, and this is being developed, and this is going to be in the market very soon.
Yeah. Now, coming to the lot of controversy was raised against TFL in ureteric stone management. Everybody has a feeling that TFL causes ureteric stricture more because primarily it has some coagulative properties, whereas homium is slightly cutting property. The lowest energy frequency is very low with the dusting of a homium laser when compared to thulium fiber laser. But practically, if you apply the principles of laser surgery, doing at the center with low frequency, low energy, fragmentation type carefully, both are same as per as literature. What is your feeling? Do you think if you have given two similar situations of impacted stone, you have both lasers with you, and what's in your mind, which laser you choose, or it doesn't make any difference? What is your personal opinion? Lot of discussion in India, negative for TFL, lot of discussion. They say that last 1 decade, significant number of ureteric strictures and reconstruction is happening after the TFL is introduced, because 90% of the Indians are using TFL 35 watts for the stone. Is it that it is used more commonly than before, or is it that the laser is causing damage in best hands also?
My regard is that it is the use of the laser, the use that the surgeons give to the laser. Same expert surgeons with 30-watt homium lasers before never talked about this. They didn't have this problem. So it's the use that you do is the use that you give to the laser. If you have a urethral stone, you can treat it with TFL, but you have to be very strict on managing your watts and especially your frequency. I think there was a lot of excess use of high frequency in the ureter that caused this. Yeah, people using 100, 400 or whatever. But if you use less than, let's say, less than 12 hertz, for example, and 12 watts or 12, what I mentioned in the,
slide,
you will be on the
slide.
Exactly, you will be on the safer side. If you have a very impacted stone and you know that you're going to be very close to the ureter, because you have to be very close to the ureter, and you may choose either TFL or homium. If I have a very impacted stone and I know that this is going to be a problem, I will use homium. Yeah,
that's all.
But
that's all I want. Exactly the same answer I want. Now coming to the thulium fiber, thulium YAG, and homium, we have seen homium laser produces lot of sound. Blast sheath recurrently gets damaged. The maintenance cost of the homium is very high. I have used 15 years homium. Now I am using a 5 years thulium fiber laser, absolutely no maintenance cost for stone in TFL. It's very sturdy and cost effective. What is your opinion? Blast sheet is the main thing. If you use a little more into the stone, if you perforate the stone and make hole, the blast sheet may get damaged in homium. Whereas in thulium fiber laser, like pneumatic, you can drill without any problem and weaken the stone. But at the same time, a lot of people say they use homium in PCNL, especially if they have 100 watts laser. So what is your take on fragmentation efficiency and the loss of blast sheath if you use inadvertently into the stone?
Okay, so going to answer those two questions separately. The first question is yes, we absolutely agree that homium laser is less energetically efficient. You need to do some special arrangements in the OR to get these 40 amp plugs, for example. It's a very difficult machine because it hits a lot. So the mirror alignment that you need very specifically to make the laser work can move, and it can move only by moving the laser over the OR. So yes, it is less efficient, the homium laser, in this regard. There's no mirrors on TFL. It's only the fiber. So you can connect it everywhere. So you don't need to be absolutely very careful. It doesn't overheat. It doesn't need these big water cooling systems. So it's absolutely more efficient and energetically efficient compared to homium. So that's the good thing. Yeah, and this is real. This is real. And the second thing is that look, we use homium for PCNL, and we have been using it for more than 20 years in my institution. And I think we've never had problems because you can use very high watts. It's a very high watts, but because it's a very different concept from PCNL, from flexible ureteroscopy. You cannot compare PCNL with flexible ureteroscopy because you can have a 24 French axis with a 16 French scope, or a 18 French axis and a 12 French scope, which is our standard. We have the outflow is amazing. All the irrigation is coming out immediately. Yeah. So there is no problems with temperature and there's no problems with pressure whatsoever because of the basic nature of PCNL. So you can use it with those kind of settings. We have used 120 watts in brushite stones, for example, that you need it to fragment and dust very well that stone and remove the fragments. And it's completely possible because of the same nature of PCNL. You cannot compare. It's not the same within flexible ureteroscopy. It's because PCNL
So you mean to say that you have slight preponderance for homium laser in PCNL with a large laser fiber. No need to think about temperature. Quickly fragment and get them out. So
this is our standard. This is what we do.
Now, last few questions, maybe a couple of questions. Why the thulium fiber laser told that 150 micron, 100 micron, 50 micron is possible, but somehow last 2 years, they could not go below 150 microns. It stopped at there. And 150 is also not used by many people. We are happy with 200. And as a matter of fact, even 200 is slightly smaller when compared to 200 homium. I have a feeling that when you use both 200s, the thulium fiber laser 200 is slightly smaller and very tender. You have to be careful. So do you think that in future, if you have to apply this simultaneously while doing the RIRS, does 100 micron laser fiber makes a difference in direct intrascope suction?
Yeah, I don't know if they haven't been not that they haven't been able to reduce the size, because they reduce the size of the coating. I have the same feeling between the two of them. But also, I don't know if I don't imagine a scenario which is absolutely necessary to have a 15, you can transmit the energy very well. And having small fibers also comes with some trouble. I have sometimes problems getting the 150 micron fiber in my working channel because it's very small. It just like
Very
pokes the
small,
working channel.
very small. Yes,
Exactly.
yes.
So 200, I even on purpose want the 200 sometimes because I can insert
Easily,
the fiber better.
better.
So
Yes,
it's like a give or take. It's better for
yeah,
some things, but it's bad for other.
yeah. So the next question is, if you have a large volume stone, if you have a good ureter, we all know that popcorning is essential at the end of the surgery, which can be done better with TFL. Is if any junior says, should I buy 35 watts laser chromium versus 35 watts thulium fiber laser only for stone disease and work, high volume work. For example, in my unit, I wanted to do faster. I have 5 cases, 6 cases per day. I use TFL. I have completely switched to TFL because in previous days, I used to powder slowly and then at the end, I leave it. Now, I fragments in the calyx fast and then go to popcorn with 100 Hz, with 100 Hz. And very fine dust in a short time will form. But there is a small risk of temperature problem. So these two, even to date, I feel that I have advantage of TFL in doing 2.5 centimeter stone in 20-30 minutes versus 30 watts laser chromium, which will take 1.5 hours or 1 hour. So I will save half an hour intrarenal flexi time with TFL. So what's your opinion?
I have the same feeling as you. I switched to TFL also for
Yeah.
most of my cases. It doesn't work for all the cases. I don't use TFL for 16 stones, for example. Yeah.
Okay.
So for most of my cases, I switch to TFL, and I have exactly the same feeling as you. I feel that I'm quicker, 2 times quick. I do surgery 2 times faster, and that popcorning is very, very efficient with TFL compared
Very,
to Homium. Very
yeah.
efficient. You can have very fine dose in very few minutes. Exactly. I don't use as much as your watts. I use, I don't know, 1 joule, 20 hertz at maximum,
Yeah. Yeah.
and it's still very, very efficient, and this is what I do. Also, I
Okay.
do exactly the same as you. Yeah.
So my last question. Tomorrow, if you have to choose a 5.5 French ureteroscope, flexible, very small, versus 8 French scope with large channel, 5 5.5 French scope with the 3.6 channel versus 8 French with 5 channel. That means I'm asking, uh, both scopes are with you after 10 years. Very small tender scope, beautiful vision, but irrigation logistics are on slightly lower side. Whereas a very sturdy scope at 7.5 scope with a good channel, which one will have future? I'm asking fans versus this.
Yeah. So I believe I believe in this. I believe that this is I don't know, I like more the concept that with one instrument you can go there and aspirate everything. This I like this idea. I like this idea. Nonetheless, imagine having a 5.3 French scope. This is amazing. You can go inside the ureter, maybe no stent whatsoever. You can do 3.6 French channel, as you mentioned, is exactly what we have nowadays. So no problem. I'm not going to aspirate everything, but I'll be super safe on the safe side. You know, it will be beautiful. But also, I would
Yeah,
like to aspirate everything and to see that nothing is remaining. That's great. So I think maybe there's options or patience
yeah,
for both of them.
both of them. And
This is
you do
yeah,
your patients feel bad when you stent and come out without doing anything and say that after 10 days I will do best? Most of our patients will feel very unhappy, and we try
yeah,
to convince, unless it is a pre-surgery decided that you are only stenting. If you
of
tell that I
course.
am doing stone and you stent and come out, whatever you say, they will not be happy.
Yes, absolutely,
So,
absolutely. I
so
have the same feeling. Yeah. They have to understand that we do it for their own safety.
yeah,
This is
yeah,
what I tell them. And there's nothing to do. I'm not going to break their ureter just to get in. Um, Yeah, and this is what that's the door that it's opening right now. Imagine that the scope is the same size of the stent. So there's no need. You won't have this situation.
yeah. So with that, we will conclude the session. Thank you very much. You are very knowledgeable. You are doing a lot of research. We are following you, and this is the one subject which is dramatically changing. And we don't know how the future of stone management. But overall, if the ureter is not damaged, and if we can manage the stones, that is always best. The entire discussion is on ureteric damage, ureteric damage, ureteric damage. So somehow
Mhm.
there is only one ureter for one kidney, so we can't damage it. So
Absolutely.
that's going to be important part in RIRS, whatever the advances that come. So we wish more topics from you, and I wish you all the best. Thank you very much for being with us.
Thank you very much, Chandra, for the invitation. It was my pleasure.
Thank you. Thank you very much.
And bye, everyone.
Bye.
Thank you.
Steve.